So would you mind recording, Sarah? Perfect. So today we're in for a treat. For those of you that don't know me, my name's Al. And tonight we have Anna, who's a Jersey City native. Shout out to Hudson County. And she did her medical school training at VCU. And she's a current third-year resident here at RWJ. In addition to all this, she was the winner of the 2021 Eastern Orthopedic Association Ranelagh Award for a presentation on COVID following orthopedic surgery. So tonight she'll be talking to us about osteoporosis, diving into why women are more susceptible compared to men, and then she's going to touch on, the pathophysiology, complications, etc. So without further ado, Anna, please take it away.
Thank you very much. Thank you guys for inviting me. Like you said, I'm a PGY3, so by no means am I actually like an expert on osteoporosis. So this is kind of like my mini grand rounds, I guess, sort of sharing. A lot of it's going to be like the resident perspective on things, which I guess will be more relevant to you guys anyways as you enter your careers. Is anybody here not going into orthopedics, or maybe is tentatively like not sure?
I think we have a bag, yeah.
Okay, cool. So I'll just, a lot of it is going to be like the orthopedic perspective. But obviously this is kind of a multidisciplinary problem. So I thought it'd be interesting if there were other people, but anyways, I'll go ahead and dive in. So the goals of this are just to kind of talk about etiology and pathophysiology, talk about some complications, talk about the diagnosis and screening and treatment prevention, and then obviously the importance. For the M3s and 4s, I guess who have taken step and have kind of already learned a little bit about the basics. I think for the 1s and 2s, at the end, I'll just sort of talk about like what I think the major take-home things are for this lecture. This can be a kind of a dry, boring topic because I feel like osteoporosis is one of those disorders that people kind of glance over and they don't really like think is like, oh my God, this person has osteoporosis. It's not like a huge life-changing diagnosis, but hopefully I'll kind of change your minds, your guys' mind in terms of the importance and significance of somebody who's diagnosed with osteoporosis. So just some overview. I think these are some daunting statistics. These were taken from the National Osteoporosis Foundation website. 10.2 million adults in the United States have osteoporosis, and over 200 million people worldwide have it. And 43.3 million people have osteopenia. And I'll talk a little bit about the difference between osteoporosis and osteopenia, because I do think it's important to differentiate those two diagnoses. Every year, 2 million people sustain a osteoporotic fracture in the United States and over 9 million people worldwide. And it is the 10th ranked major illness in all of Medicare beneficiaries. So it's pretty common disease. And the ratio tends to be for every 1 male, there's 4 females afflicted. So it's a more heavily affecting the female gender disease. So some other statistics regarding how it affects women more than men. 61% of osteoporotic fractures occur in women. Women are 45, women over 45 spend more total days in the hospital secondary to osteoporosis, whether it's complications from osteoporosis, more likely fractures, versus breast cancer, MI, and diabetes combined. Half of women and a quarter of men will break a bone in their lifetime due to osteoporosis. And for women, this incidence is greater than that of those heart attack, stroke, and breast cancer. 25% of osteoporotic hip fractures are in men. And the 1-year mortality is 20% higher than in men, actually. So I think even though it's important to know that even though women are more affected, if you're a man and you have a fracture, then you're more likely to die from it, which is also a very scary statistic. And osteoporotic hip fractures are on the rise. They're not downtrending. And it's estimated that by 2050, the incidence will increase to 240% in women and 310% in men. So obviously not a problem that's getting any better. It's just getting worse, especially as our population is aging more and more. A side note, it's also a very costly disease to have. Osteoporosis related fractures cost patients and their families and the healthcare system over $19 billion annually. And by 2025, it's predicted that osteoporosis will be responsible for 3 million fractures, resulting in $25 billion in costs. So this is me mixing in my orthopedic knowledge and hopefully trying to engage you guys a little bit. Does anyone want to just see what they, or say what they see here?
Looks like there's a femoral neck fracture.
Wonderful. So there's a left-sided femoral neck fracture. This is just a spot shot of somebody we actually fixed last week. This person was quite old. He was 94 years old and fell from ground level. And then the following person, this is a person we did last week as well. This was like a 78-year-old person who fell at home and had this left hip intertrunk fracture. So ultimately, both of this, the first person underwent a hip hemiarthroplasty, and then the second person underwent this intramedullary nailing. So these are two cases that I was involved in. And if you've ever been to Fracture Conference, you'll notice that almost everybody is presenting like a hip fracture of some sort. We kind of gloss over the vertebral compression fractures. That's also a very common osteoporotic related fracture. But it's, we kind of just glance over it like, oh, they had a hip fracture and then we fixed it. But these are actually like quite detrimental to our patients. And they're obviously very, very, very common. So this is kind of like a pause moment because the 1-year mortality after a hip fracture before the age of 50 is extremely high. And this number has just been kind of stagnant. We're not getting really any better at it. The mortality rate is 25 to 30%. So of all the people that we present every week at Fracture Conference, at 1 year, statistically, a quarter to a third of these people are going to be dead, which is a terrifying thought because people come in through the emergency room every day. Almost every day, there's somebody who breaks their hip and then we fix it. And then, the mortality rate is insane. And at 6 months, only 15% of these people can walk across the room unaided. So when we're talking to patients preoperatively and their families, and they're asking, they want to just go back to where they were before, most of them won't. And it's a really hard conversation to have. And I don't know if everybody has this conversation as extensively as they should. But a quarter of these people end up in nursing homes, so they lose their independence. They never really get back to where they were before. And half of them never end up where they were before. And I know countless stories of family members who have sustained hip fracture. They get it fixed, everything, the surgery went phenomenally, but they just never got back to their baseline. And that's kind of a terrifying thing to hear, especially as an elderly person and as a loved one of somebody who's elderly and has one of these fractures that, if you have a high chance of death at a year. And if you survive that 1 year, you are probably not going to be where you were before, which to some people may be worse than a death sentence. So I just wanted to highlight this fact because this is one of the things that if you were to take anything away from this lecture is that, these hip fractures are osteoporotic fractures. It's a complication of osteoporosis that's quite common. And osteoporosis is it's a quite preventable disease and we're not getting any better at treating it. And we really should. And similarly, vertebral compression fractures have also a pretty high mortality rate, 15% mortality at 1 year, which is less than a hip fracture, but the 2-year mortality is actually quite similar to hip fractures. So it's kind of a big deal. Like I said before, we go through Fracture Conference and we're a little bit unfazed by this. We're like, oh, 87-year-old person fell, had the hip fracture, we fixed it, next, move on. But this is a big deal for these patients. And we need to think, especially as orthopedists and being the front line of these fractures, we need to think more about how these are impacting our patients and how we can prevent them. So we'll backtrack a little bit now that I've been really morbid and talked about the death mortality rates to talk about just what is osteoporosis. So osteoporosis is a quantitative, not a qualitative disorder of bone mineralization. So that's important to distinguish because it's not that you don't have we often say when we're doing I'm guilty of this too when we're doing at Fracture Conference, you're like, oh, it's crappy bone, but it's not the quality of the bone. It's just they don't have enough of it, of the bone mineralization. So I'm guilty of it. I say it all the time, and attending say it. We're all guilty, but that's really not what we mean. And so it's kind of a balance of osteoblastic bone formation versus osteoclastic resorption, which is a normal part of bone metabolism. But as we age and people who are afflicted with osteoporosis, their metabolic scales tilt toward more resorption and not enough formation to make up for that. So yawn, it has to do with like rank and want pathways, which I'll touch on a little bit. I don't really want to go too much into it because I think that's just going to make everybody go to sleep after their dinners tonight. And that's not really what I think the purpose and takeaway of this lecture should be. So what is important to know is the WHO definition, the World Health Organization definition of osteoporosis, and that is a bone mineral density measure by DEXA, or dual energy X-ray absorptiometry, mumbo jumbo, it's just DEXA. That is 2.5 standard deviations or more below the average for a young, healthy woman. So this is the T-score versus the Z-score, which is for people who are like age and sex matched and ethnicity matched. The T-score is compared to young, healthy women. So that's people who are in their 30s, where your bone mineralization is at its peak. So you just need to be below 2.5 standard deviations. So osteopenia, on the other hand, is just a T-score less than 1 standard deviation from the young, healthy baseline that they're comparing to. So osteopenia is -1 to 2.5 standard deviations, and osteoporosis is less than 2.5. So it's just kind of a spectrum, but it's an important definition to understand. So just some background. Again, I don't really want to bore you with all of these like molecules and signaling pathways because I just hate it. I learned it at one point and I still know it. I just don't really want, I don't want to put everyone to sleep this late. It's very interesting and it's very complex. But basically there's this pathway of, and balance between osteoclasts and osteoblasts. And just in general, as you age up until about 30 years old, your bone mass is increasing. So I'm 29, I'm about to be 30. When I was making the slide, I was like, oh my God, I'm like at my peak right now. I'm gonna be on the decline before I know it. And this is really depressing, but it's true. So, we're at our peak right now. And as we get older, our bone mass will start decreasing by a couple percentages every year. And that's just something that we have to deal with. And so the importance of this is that as we age, particularly women who undergo menopause, and menopause is this thing that, obviously only women go through, but it's important because hormones impact our metabolic balance of this osteoclast versus osteoblast formation and bone formation. And so men don't have this giant shift in hormonal balance, but women do. So when women hit menopause, we suddenly experience this estrogen deficiency, which tilts the scale towards bone resorption way more rapidly than men have it. Another great thing about being a woman, my side note about, anyways, moving on. And so when women undergo menopause, we suddenly have this decrease in bone mass. And so we're much more likely to have osteoporosis, which is why in the beginning, I was saying that women are, 4 times more likely than men to have osteoporosis. But that's not to say, I think a lot of times people think that it's a disease of women, but and then men who have osteoporosis are kind of overlooked and are not treated appropriately. So it is important to sort of make this a not gender specific thing, but it should be on your radar for anybody who has like a hip fracture or vertebral compression fracture, especially when they're over the age of 50. So yawn, another slide that I promise I won't go too much into. But basically, you have parathyroid hormone is activating osteoblasts. Osteoblasts release rank L. Rank L goes to the rank receptor on osteoclasts. And then this just kind of becomes important because parathyroid hormone is a target of some of the treatments for osteoporosis. It's just important to know that that PTH and then rank ligand are targets for treatments. So in summary, I thought this was a good chart that just sort of talks about the different factors that are involved in bone remodeling. So obviously calcium is good, vitamin D is good. Parathyroid hormone increases osteoclast formation. so that it actually increases bone resorption. And the way I remember this is, I think we also always learn in medical school that it's phosphate trashing hormone. So it takes you're decreasing your phosphate, and in order to accommodate that, you start drawing calcium from bone, so it starts resorbing bone. What's kind of confusing about this is that it also can work in increasing bone formation. So one of the treatments is actually a parathyroid hormone type analog. And so it's actually a little bit confusing, but it's just important to remember that PTH overall will stimulate bone resorption, but if you're using the molecule as a treatment, it's actually a promoter for bone formation. And then, we talk about calcitriol, calcitonin, TSH, estrogen, which we talked about a lot, which inhibits bone resorption, and testosterone. I won't read the slide to you. I can send this PowerPoint to you guys if you want to look at how wonderful my slides look. So overall, there's just some risk factors, and I broke them down into modifiable and non-modifiable. So obviously non-modifiable, we can't change if we're female, you can't change your ethnicity or your age as you get older, and you can't change your genetics or family history. But I want to focus on the modifiable because those are the things that we can really change and have a huge impact on osteoporosis, and are good targets for treatment and prevention. So smoking is really, really bad for all sorts of reasons, but obviously for osteoporosis, it can make you a lot more susceptible to lower bone mass. And so smoking cessation is a huge modifiable risk factor that if you can get women to stop smoking, especially as they get older, you can hugely impact their risk for osteoporotic related fractures or just osteoporosis in general. Low BMI, so you think of older, frail ladies who are probably nutritionally are lacking and are just really frail and weak, and that's something that we can help just by getting proper nutrition and getting their BMI to a healthier level. Lack of exercise, it's really easy to just become complacent with just sitting in front of a TV as we get older, but it's important to encourage everybody, but particularly as you get older, to continue to do weight-bearing exercises that can exercise the bones, because if bones are one of those things where if you don't use it, you lose it, and so it needs that constant stress of the world and impact in order to maintain its normal bone mass. Alcohol use, obviously bad, and then estrogen deficiency. There are some ways that we can modify hormonal imbalances, and then obviously low calcium and vitamin D, which I think go along with nutritional imbalances. So in general, the workup is pretty extensive. It's just important, I think, to notice that 80% of Americans who have a fragility fracture, so that's these hip and vertebral compression fractures, are not properly screened for osteoporosis, which is bad. 80% is huge. And that is something that we can hugely modify by just, putting in some labs and just screening people. So I know that at Robert Wood Ortho, we have this order set that we, actually underutilized, but we've been promoting it more and more. It's literally just it's super easy. You just type in Ortho Frag, and it's just Frag lab sets, and it has all of these different endocrine labs, calcium, vitamin D, thyroid panel, PTH, CBC, testosterone levels, and it's just super easy. And we should be doing it on almost everybody who sustains either a vertebral compression fracture, these LC1 pelvis fractures from a ground level fall, and especially everyone who has a hip fracture. Because really, if you fall from ground level, you should not be breaking things. That's just not normal, especially the biggest bone in your body, your femur. So something's wrong metabolically with you if that's happening. And we just kind of glide over that whenever it happens. And so it's important to my point of that statistic is just to sort of emphasize that we need to work these people up. And all of it kind of starts with just a proper history and physical. So it's important to just identify risk factors, which I talked about before, both the modifiable and non-modifiable. Any history of fractures, every osteoporotic fracture that you sustain makes you that much more likely to have another one. And so it's important to, especially if you get your number one, you need to stop it there and get them worked up and treated appropriately to prevent future ones. Any sort of, underlying diseases that could be related. Medications are important to know. There are some medications, particularly steroids, that can have vast impacts on your hormonal imbalances, as well as just your your balance of osteoclast, which is osteoblast formation. Their exercise, alcohol and tobacco use, diet, any history of falls, which is important to know just because you want to know what their risk is of falling and then subsequently breaking something, as well as family history of osteoporosis, and then whether they're in menopause or not. I admit, as an orthopedist who is running around the hospital and seeing these people in the emergency room, my history of physical are lacking somewhat. I sort of focus on like, big ones like meds. I don't really ask them about like their exercise. I'll usually ask them about tobacco or smoking and alcohol, but I'm not going like hugely into family history, but probably that we should be. And then any surgical history, especially any endocrine GYN procedures that could tilt their hormonal balances. And then physical things that you're looking for are height and weight to calculate BMI, so you know whether they're in that low BMI range. That's kind of scary for osteoporosis. Kyphosis is kind of significant because that can sort of allude to underlying compression fractures, which will tilt your spine into a more kyphotic presentation. And that'll just give you a hint that they have already sustained a vertebral compression fracture, and you would be more attuned to thinking that, oh, they probably have osteoporosis. Any neurological disorders, and then just overall muscle mass and tone. And then I mentioned before, the lab tests that are super easy to put in are calcium, vitamin D, thyroid, parathyroid hormone, CBC, and then testosterone levels. And then ultimately, the diagnosis relies on the Dexa scan. So what is a Dexa scan? I'm going to be honest with you. I've never seen a Dexa scan. I have seen the results in the office. I know that UOA, where our attendings work, they have one there, and they have this awesome nurse who will perform the Dexas and then interpret it and then refer them appropriately to orthopedics as well as endocrine and their primary care physician. But in general, it measures the bone density at the femur and then the lumbar spine, which are obviously the two most important areas because that's where you'll sustain osteoporotic fractures. And then it compares these densities to age-matched reference controls of young adults. That's the T-score that I was talking about. And so the report of a Dexa scan will include the bone mass density of the peritrophic regions of the femur, the neck, and then usually the lumbar spine area. And it'll calculate T and Z scores for each region. So then you have your T scores to determine whether or not it's osteopenic, normal, or osteoporotic. And that's, again, -1 to -2.5 standard deviations of the T score is osteopenia, and then less than 2.5 is osteoporosis. So that's how we're diagnosing these people ultimately. And this was just me explaining what the difference between T and Z scores is, which may pop up sometime in the future. So who do you even need to do a Dexa scan on? I think this is important because that way, you know who is supposed to be getting these scans. And I think as orthopedists, we should be trying, especially people who sustain fractures, asking people if they have a Dexa scan or their primary care physician. Endocrinologists, a lot of like OBGYNs are doing this as like sort of the PCP role, is just getting people into their Dexa scans appropriately. So all women over the age of 65 should be getting a Dexa scan. Patients with secondary osteoporosis, postmenopausal women who have low energy fractures. So that's anybody who falls and breaks their femur or spine, like that shouldn't be happening from a ground level fall. Any incidental findings of a spinal compression fracture, which actually surprisingly does happen quite frequently, and we get consulted about it. Anybody who's had steroid treatment greater than 3 months. Any women who have menopause under the age of 40. Any history of osteoporotic fractures in these younger women. And then also people who have like extremely low BMIs. Any history of a low energy fracture, smokers, and then again with the steroids. I think it's also important to just note that in men over the age of 70, and then younger men with the risk factors of having these low energy fractures should also be screened. So you can't just think of women again, men are also afflicted. So like I said, the diagnosis is ultimately dependent on the definition. We're using T-scores, which is 2.5. And then it's also important to know that other than the WHO definition, the fracture criteria can also make you give you the diagnosis of osteoporosis. So everybody who falls and breaks their hip or spine, they have osteoporosis, regardless of what their Dexa says. So it's important to think about that when they're coming in and whether or not they're getting the appropriate treatment after their surgery. And then I kind of just already said that. So now I'll just talk a little bit on the treatments. And basically the treatments can be broken down into resorptives, anti-resorptives, and then anabolic agents. So the anti-resorptives are inhibiting bone resorption by inhibiting osteoclasts, which are the cells that break down bone. And then there's anabolic agents, which are promoting osteoblastic bone formation. A little bit of interesting side note here. There's some research that is ongoing on the timing of treatment. And so some people think that you shouldn't be starting osteoporosis treatment immediately after, like say someone comes in with a hip fracture, like when should you start their treatment? Do you need to wait a certain amount of time after you treat them, or should you start them immediately? And there's not a lot of like high level of evidence data. But most of the research that does exist says that there is no real difference. And there's like basically a theoretical risk that by starting these treatments, because you're tilting the balance of osteoblastic and osteoclastic balance, you are disrupting the ability for callus remodeling, which is obviously part of bone healing. And so because of that theoretical risk, a lot of people were like, maybe we should be treating these right away. We should let the body take its course, let the osteoclast and the osteoblast duke it out and remodel. And then, but obviously, like I said, there's not a lot of evidence to prove that that's true. So there was a couple of trials, the Horizon trial and the Freedom trial, that kind of looked at various treatments perioperatively, and they didn't really find any increase in non-union rates or delayed healing. So going back to the anti-resorptives, we talk about, and you'll hear a lot about the diphosphonates or bisphosphonates. These are medications that work in two ways. There's the nitrogen containing and then the non-nitrogen containing. And usually we talk about the nitrogen containing, which is a synthetic analog to pyrophosphate. And then there's the non-nitrogen containing, which is a toxic ATP analog. But overall, basically what it does is these inhibit osteoblasts. There's also the rank L monoclonal antibody. So rank L, we talked about being involved in class survival. And so this is an antibody to rank L, which will then decrease your amount of osteoclast survival, therefore promoting bone. So that's denosumab. And I don't really want to read all of these different bisphosphonates. There's a lot of them, but basically that's how they work. And then there's also raloxifene, which is a estrogen receptor agonist in bone, but an antagonist in breast, which is important because obviously you don't want to just shoot people up with a bunch of estrogen, because then that can cause a lot of other issues. So raloxifene is a good way to specifically target bone estrogen receptors. And then another medication that is often used, or I wouldn't say often used, because I haven't actually seen it being used a lot, but is there's some research that shows that calcitonin is good for treatment of acute vertebral compression fractures, particularly analgesia. As an analgesic, I honestly haven't seen that being used a lot, but I do know that there's literature to support that. So these are the anti-resorptives. Again, I think it's just important to know that there's the bisphosphonates are basically inhibiting osteoclasts, if you're to take anything away from this really boring slide. Another important part about bisphosphonate treatments is that there is a risk for atypical femur fractures. The incidence is 3 to 50. Oops, my AirPods are dying. 1 second.
Okay, sorry about that. So these are not super common, but they do happen. We just fixed someone who sustained an atypical femur fracture on Sunday. For a lady who had been on bisphosphonates for 10 years. The incidence is 3 to 50 in 100,000, which doesn't seem like a lot, but it's important to know that your risk of these increases with longer term use. So there's kind of a balance between, treating people with bisphosphonates in order to decrease their risk of osteoporotic fractures. However, by the longer these patients are on bisphosphonates, their risk of having these atypical femur fractures also increases. And so this picture to the right is showing some beaking on the lateral cortex, which is a common thing that we can see on x-rays. Prior to it breaking, a lot of them will have antecedent pain, meaning like pain before they break through their fracture. Basically what happens is that you get all of this excess bony formation on the lateral cortex, and then that forms a stress riser. And then, from a normal fall, they'll just crack right through it. You just can't win, really. So then going on to the anabolic agents, these are, again, the agents that are promoting bone formation. The two major ones are teriparatide, also known as Forteo, which is a parathyroid hormone peptide analog. And then its close relative, parathyroid related hormone analog, which also goes under the name Tymlos. I haven't really seen anybody on that. I know a lot of people on Forteo, which is kind of like the big guns of osteoporosis treatment. These are the agonists of the parathyroid receptor that act in a way to promote bone formation. These are typically a self-injection. They're very costly, but they are super strong, like I said. So people who have severe osteoporosis are often treated with Forteo. I think it's important to know, though, that they are contraindicated in people who have Paget's disease or have a history of skeletal radiation, because there's this slightly increased risk of osteosarcoma in these patients. So I think equally, if not more important than treatment of osteoporosis, is the prevention, because like I said before, these are super, super common. And we as physicians and orthopedists are kind of responsible for appropriately treating these fractures, but also referring them to people who can manage their osteoporosis. Because like I said before, when you have one osteoporotic related fragility fracture, you're way more likely to sustain another one. So we need to nip it in the bud early. There is a movement called the Own the Bone, which was started by the American Orthopedic Association, also known as AOA, which has been targeting preventing these fragility fractures by using a multifaceted approach, including the nutrition counseling, so the calcium and vitamin D, targeting these modifiable risk factors, having them increase their weight bearing and muscle strengthening exercises, fall prevention to prevent people from, putting themselves at risk for sustaining these fragility fractures, and all those other things that I talked about in terms of their modifiable risk factors, as well as just appropriately diagnosing them and then starting them on treatment. There have been some studies that show that, treating patients appropriately can hugely decrease the rate of fragility fractures, obviously, which makes sense. But I think that's just important to remember, again, because we can prevent so many of these people from sustaining these fractures, and therefore, either dying, because like I mentioned before, Morbid Anna bringing out the statistic that, a third to a quarter of these patients will die at a year, or never return back to their baseline. So we can totally prevent that for a large portion of these patients. A really easy thing to do to prevent these fractures and complications are to just have a good dietary supplement, such as calcium and vitamin D. And the recommendation right now is broken down by age, but these patients that have these fragility fractures over the age of 50, they are recommended to have 1,200 to 1,500 milligrams per day. And then, these are similar for patients who are being treated for a healing fracture in a long bone. We often put them on supplementation, and then vitamin D requirements as well. So these are really easy, like over-the-counter supplements that patients can buy, and that we should be recommending to everybody, especially when they sustain a fragility fracture. So I wanted to touch base a little bit on risk stratification. So this is important to determine if someone should be treated for osteoporosis based off of their estimate for their 10-year fracture risk. And then also kind of figure out what pharmacological agent they need to be on. Since most of us here kind of said that we're going to be in orthopedics, I don't really think it's our job to prescribe a lot of these treatments, but we should be aware of them because a lot of patients will be on them. I think endocrinologists and PCPs will be the primary leaders in actually prescribing these medications. There's a really important tool that we use called the Fracture Risk Assessment Tool, or FRAX. And this is a kind of a survey that, and I'll go through it at the end because I do think it's a really easy and important exercise to go through that can estimate your 10-year fracture risk. So it takes like 2 seconds to do. But if you have a 10-year probability score based off of the FRAX tool of 30% for hip, 0.3% for hip, or 20% for any other major fracture, or you are a WHO-defined osteoporotic patient, then you are indicated for treatment of osteoporosis. So we've talked about a couple different indications for treatment. A fragility fracture, so that's a hip or vertebral compression fracture from a low energy mechanism. Whether your your T-score is is less than 2.5, or if your FRAX estimate meets criteria, then you are eligible for osteoporosis treatment, and you should talk to your doctor about that, or your doctor should talk to you about that, I guess. And overall treatment is very effective. So like I said before, a lot of people have this, it's really detrimental, but we can treat these. So calcium itself has been shown to reduce fracture risk by 34%, which is a huge percentage. Vitamin D can also do it. So those are two really easy supplements that can hugely impact and decrease your risk of fracture. And then going back to the bisphosphonates, alendronate and risedronate can reduce your risk of vertebral compression fractures significantly, as well as hip fracture. So if we can properly screen these patients and treat them either before or after their first fracture, then we can prevent a lot of people from sustaining these terrible, terrible injuries. So ultimately, our job as orthopedists, we're at the front line of identifying these patients because they are the ones who are falling and coming into our hospitals, and we have to, fix their hip fractures, which is a beautiful operation to perform. But we sadly we can prevent these people from having these terrible, terrible injuries. And so once we have people who come into the emergency room, we fix their fracture and high five each other. We should also be thinking about screening these patients for osteoporosis, and then making sure that they are properly evaluated and referred to either an endocrinologist or their PCP who can treat their osteoporosis and prevent future fractures from osteoporosis happening. There have been a lot of pushes for fracture liaison services, which is hospital-based, that improve fracture prevention by basically utilizing like medical services, endocrine services, geriatrics, and orthopedics in order to promote the early diagnosis and treatment of osteoporosis. So if anything, I'm sorry, I actually took all of the 40 minutes, I guess. I was actually trying to make this kind of short. The major takeaways of this lecture is that the definition of osteoporosis is a quantity problem, not quality. This is a largely untreated disease that is kind of silent until you fall and then break your hip or your spine. I don't think enough people are talking about it, especially given the number of people that it affects, and the impact that it has on people's quality of life. And then, it can be life or death. And then it's our job as orthopedists to identify and refer patients for proper treatment. And then ultimately, it's going to be a multidisciplinary approach in order to take care of these patients in a meaningful way. So these are the resources that I use. Obviously, they're very generic, but I just wanted to take a minute, if you guys can still see my screen, to actually go through this FRAX tool, because it takes 2 seconds. You can literally just Google FRAX. There's a lot of different websites. This is the one that I like to use. But if you don't do this on a family member, because it's kind of scary, But you can literally type in like, I'm going to pretend I'm 70. I'm a female. I don't know my kilograms, but I'm going to say 70 because that's like the average. I'm pretty short. I'm going to make up a number.
Real quick, Anna, I don't think we're able to see your screen. I think you're just sharing the PowerPoint.
Hold on. Do you see this? No?
Not yet, no. Oh, well, we see your mouse moving right now. Yeah.
How about this?
Now we see it. Perfect.
Okay, sorry about that. So this is the Frax tool. And so I'm typing in like, I'm 70, I'm a female. I made up some numbers here. We'll just make this up that like, yes, I like broke something before. I don't smoke. I don't have steroids or RA. I'm not going to be an alcoholic. And then you don't necessarily have to put in your bone marrow, like your Dexa scores, but you can calculate it and it'll tell you your 10-year probability of fracture. And this is saying that like, I have a 12% risk of sustaining a major osteoporotic fracture and a 3.7% chance of sustaining a hip fracture in the next 10 years, which is bad, in which case I should probably talk to my doctor, or my doctor should talk to me about starting treatment to prevent that. So a super easy tool to use. It takes all of 2 seconds. And I think as orthopedists, this is like just a very not time consuming way to quickly assess patients and then figure out who we should be referring to the specialists. So that is all I have. I hope it wasn't too boring. I hope you guys learned something. I'm trying to stop sharing my screen. There we go. I don't know if you guys have any questions about my lecture or anything else, but I'm happy to answer them.
Great. Thank you so much for the lecture. It was definitely informative. I had a question regarding just looking at x-rays for women or men who are osteoporotic. Is there a way to tell based off the x-ray, like before fracture, I guess, like would they have like thinner cortices? Like are there radiolucencies?
That is a really good question. And technically you cannot diagnose somebody with osteoporosis just by visualizing their x-rays. We can tell if someone's osteopenic, and I don't think I could tell you like a specific criteria other than kind of like you see patterns and you'll notice that they're like, their cortices are more lucent, and you'll kind of notice kind of like demineralization, because bones should obviously be very like bright and white, especially the cortices. And for people who have at least osteopenia, you'll be able to see sort of like almost, it's just like lighter looking and more lucent. And it almost just looks like someone took the transparency dial and just like dialed it over a little bit. But I don't know. I mean, there's probably like a definition where you could like plug it into a computer and like, they could tell you like, oh, there's this many pixels or something. I don't know. But a lot of us, I think when we're looking at x-rays, we say like, oh, they have really osteoporotic bone, but technically you can't say that because osteoporosis is a definition based off of the T values, like I said, and you obviously can't like read those T values off of just a plain x-ray, but you can tell if someone's osteopenic, and you can make you can probably like assume, I mean, you can definitely say if someone has osteoporotic bone if they have a femoral neck fracture, and then also their bone looks like osteopenic, because then, they had sustained a fragility fracture, which kind of defines them as a osteoporotic patient. But yeah, that's a really good question.
Okay. To that end, are there certain fracture patterns that you've kind of picked up on that osteoporotic patient is more predisposed to?
Yeah. So in general, the two most common are vertebral compression fractures and hip fractures, regardless of the hip fracture, whether it's interchoke and femoral neck. They're both considered from a low energy fall. That's like just like falling in your kitchen or something. Like you shouldn't be breaking your hip. So those, just any of those, all of those are bad. And which is why I was trying to say that, like, we see so many of them and then we kind of just like move on. We're like, oh, they had hip fracture, next hip fracture. Like that's like not a normal thing. And people who have hip fractures, that means that something is going on. So hip fractures, vertebral compression fractures from either falls or just like the weight of the world. And then oftentimes like distal radius fractures are common in the elderly. They're also common in the not elderly, but like low energy mechanisms are sort of are pretty common. But there's also like insufficiency fractures. So like LC1 pelvis fractures and like old people who fall are also kind of concerning for people for osteoporosis. So that's where you see like pubic rami fractures from a fall. Like you shouldn't be breaking your pelvis from just, falling on your bottom. And so those are kind of like the main ones. The most significant ones, though, I think are the hip fractures, because those are the ones that we know are associated with high mortality, and we need to bring those numbers down.
Okay, thank you.
I was wondering if you could kind of describe the connection between like chemotherapy and bone loss. And
between what?
Like chemotherapy or radiation therapy.
Oh, I wish I could give you a really good answer on that. Chemotherapy, depending on what it is, a lot of them target different mechanisms. So in general, I don't know if I can answer that question just because there's so many different things that it targets. But in general, when I see patients who are on chemo for whatever cancer they have, chemo tends to just throw everything out of balance in your body, and so they're immunosuppressed, they are hormonally suppressed. And a lot of their normal signaling pathways are completely just thrown away, and your whole ability to heal and grow are just completely out of whack. And so that I wish I had a better answer for you, but like there's so many different types of chemotherapies that in general, like that's my orthopedic way of interpreting that. Sorry, I don't have a more specific answer for you.
Oh, that's good.
But like anybody who's on chemotherapy or like has radiation, their metabolism and especially bone metabolism, like balance is just like thrown off. And so they're at higher risk of osteoporosis and then certainly fragility fractures.
Got it. Thank you.
You mentioned that there were like certain endocrine procedures or gyne procedures that puts patients at increased risk. Could you kind of give us some examples of what type of procedures we should look out for?
Yes. So in general, thyroidectomies, parathyroidectomies, there's not an insignificant number of patients who have like hypothyroid or like had like a thyroid nodule and had their thyroid removed. And should be on treatment, but they may not necessarily be on treatment or the appropriate treatment regimen. Those are the two major ones in terms of endocrine. GYN wise, patients who have had like hysterectomies for whatever reason, their hormones are also thrown out of balance. And so they are often at an increased risk for having osteoporosis. So those are the major procedures and the most common ones that I hear about in patients that kind of alert me that I should be thinking about osteoporosis or an increased risk of osteoporosis. Part of the problem with this is that most of the people that I meet, because I'm hospital-based as a resident, I meet people when they've already had a fracture. And so when I'm getting their history, I've like found out almost like too late. I'm like, oh, like what medications are you on? And they're like, oh, I've been on bisphosphonates for 10 years. I'm like, all right, too late. You have like an atypical femur fracture or femoral neck fracture. I'm like, all right, like what is your medical problems? And they're like, oh, I had a thyroidectomy 50 years ago. And like, I forgot to take my levothyroxine. Like, it's almost like a little bit too late, but like, we're kind of like we're still like the front line in the sense that like still 80% of people don't get screened appropriately. And we kind of are seeing these people at their like first signal that something's going wrong, and we need to start like sending these people to endocrinologists and their PCPs to get them on appropriate treatment and screen them and to prevent future injuries.
Okay. Does anyone else have any other questions? I have a couple more, but I don't want to hog.
I have a quick question. I was wondering for patients with like repeat osteoporosis related fractures, do they tend to fracture not in the same location, but if they had a lumbar compression fracture, does that mean that they're more susceptible to having more of those, or does it really not matter?
Statistically, yes. Once you sustain one lumbar compression fracture, you are that much more likely. There's actually statistics. I'm forgetting it right now. You are much more likely to sustain another compression fracture. And then there's also, you're also at an increased risk of then also sustaining like a femoral neck fracture. I don't think it's necessarily like, oh, you're just going to keep getting compression fractures. You're just at an increased risk for fracture period, just because your like bone is, your bone mineralization is so low. I was about to say your bone quality is low, but then I would be kind of going against my whole lecture. So.
Thank you.
We have a question in the chat. It says, do you see any associations between postmenopausal women with cardiovascular conditions and osteoporosis?
So I don't know of any literature on this. I will say that in general, a lot of patients who have osteoporosis and osteoporosis fragility fractures, a lot of them are just sick in general. And I don't know what the like underlying, I don't know if it's just because like sicker people have like poor nutrition and then are more likely to have osteoporosis. So like, for example, we see a lot of patients who have like CHF, and part of that could just be that, you know, there are patients, a lot of people have CHF. And part of that may be, you know, part of it could be medication based, and part of it could be that these patients who have more medical problems tend to be just more sick in general, and then have poor metabolisms, and therefore like bone metabolisms, and then osteoporosis. But I don't know of any like specific studies that I can cite for you. Great question. Don't have an answer.
All right, so I have two last questions. So the first one being diet. So after, you know, someone comes in, they sustain a fracture, they're osteoporotic, you put them on a supplement, and maybe they're taking some meds, right? Do you ever, like, I know you're gonna have to, you know, maybe like address like maybe some lifestyle changes, like maybe you put them on like a weightlifting program so that they can try to build up some bone after, you know, they've fully recovered. Do you ever like, how do you suggest any diet changes? Like, are you telling them to drink a bunch of milk, or you know?
That is also a really good question. And I think that goes back to the multidisciplinary approach. There is actually in our order set that I mentioned before, the Fragility Frag Lab order set, not only are there labs to screen patients, but there's also an automatic dietitian or nutritionist consult that's placed. And to be honest, I don't know specifically what they talk about. I've never like sat in on one of those. But in general, I believe that they talk about like just proper nutrition and ways that they can get appropriate like vitamin D and calcium. It automatically puts them on vitamin D and calcium, and then different ways of incorporating more nutritious foods to help their bone mineralization. So that is an important part, I think, of these multidisciplinary approaches. Like I said, even though orthopedists are the ones who are diagnosing people a lot with these fragility fractures and potentially could be referring a lot of patients, I think it's a big thing, like geriatrics, PCPs, nutritionists, dietitians, physical therapists who work with patients, OBGYNs. Like there are a lot of people who are involved in making sure these patients are appropriately counseled, treated, and then put on preventative measures. I hope that answered your question.
No, yeah, definitely. And then, are you ready for one more?
I'm ready. Bring it on. Hard.
So I saw that it was patients with low BMI, they were at an increased risk and they get screened earlier. Mm-hmm. Would patients with, I'm kind of surprised that patients with like a higher BMI wouldn't also, you know, have that predisposition, because like the way that I think about it, there would be increased load placed on that bone. So like I would think like after time, like after, you know, repetitive, you know, activity, like they're eventually going to fracture. But then I'm also thinking, well, maybe because they have that increased load placed, then maybe that's what's, you know, causing their bone density to like increase.
Yeah, I think you're exactly right. So there is I think a greater association with lower BMI patients, even though they have like less mass to fall on, and stress their bones. Their bones are just overall weaker, and their bone, like I said, like bones need stress, like in order to grow and promote the tilt towards bone formation rather than bone resorption. And so part of the reason why I think higher BMI patients, I think there is an association, like I think you're right, like high BMI patients, when they fall, they have more weight to fall with, but they also have greater weight bearing forces on them daily just to get up and live. And so their bones are experiencing daily greater forces than lower BMI patients. And so their bones, because they're experiencing those weight bearing forces, their bones are a little bit less susceptible to being osteoporotic because of that, like unintended exercise of just like getting up and living, than the patient who has like a BMI of 4, made up number. And even though they have less force to fall down upon, they just have like no stresses on their bones. And so, you know, they don't use it. And so they lose it. But yeah, I mean, you have all like totally valid points.
Yeah. Well, thank you so much for fielding all my questions and for giving such a great talk. We really appreciate it. Would you mind if we send out the slides to the rest of the group?
Absolutely. Yep. Please do. I'll send them to you, I think, right? I think I have your email.
Yeah, you can send them to me or anyone else on the e-board. That'll do. And then if no one else has any questions, we really appreciate you guys, you know, coming out to this talk, and we look forward to seeing you at the next one.
Thank you guys. Appreciate it.